Thank you. I presume I just move on? Yep. Okay. So apologies if I feel a bit nervous. There's three potential reasons. One is my father was a lecturer in anatomy and reckoned it took 2 years to teach med students anatomy, and I've got half an hour with a mixed audience. So I've tried to pick, I'm aware that some people might be more interested in traumatic injury, some more interested in noxic, some might be more interested in stroke. So I hope there's something in the audience for everybody, but yeah, there might equally be bits that you probably don't feel are quite so relevant, but we'll see how it goes. My second reason for being nervous is sort of unplanned. My wife had a bicycle accident this morning and I had to rush home to kind of disentangle her from her and her bike and her dress and her bike, and probably the biggest concern at this stage is the dress. But yeah, that meant I arrived here just on time, which made a few other people nervous. And the third, probably the most important reason for being nervous is I've been in this hall lots of times before and it's always been for a comedy show. And yeah, sorry, I'm not a comedian. But anyway, here goes. I think there is a kind of a sense of sequence to what I'm going to speak about, but let's see. So first of all, to give you an idea of what's meant, you'll often hear the term upper motor neuron injury, lower motor neuron injury, and a lot of you will have come across issues that people have with spasticity. So I'm just going to try and explain a little bit about how spasticity happens. So you're all familiar with the kind of concept of reflexes. If someone hits me with a tendon hammer in here, my arm jerks up. If I stand in a pin, my leg pops up immediately. And that's something that happens at a spinal level. There's some sensory information comes in, the spine processes it really quickly and does something motor to respond to that. And that's a fairly straightforward reflex. There are a lot of reflexes that are a bit more complex than that. So as I'm standing here, the reason I don't fall over is that subconsciously, if I tilt to one side, that creates pressure on my feet. It creates a stretch sensation in my legs, and that generates reflexes in my spine that pull me back up into a vertical position again. So actually we have reflexes firing continuously, even though we're not aware of it. Without reflex pathways, you would all be lying on the floor right now. Okay. But we want to be able to modify those reflexes. We don't want our muscles contracting vigorously all the time in responses to minor changes in position. So there's a bit of conscious overriding. So in part, actually if I'm tilting forward here, it might be because I want to start walking over here. So I suppress my reflexes and I consciously do it. And there's also a bit about controlling and modifying how quickly my reflexes might happen. So if I'm reaching out for something, I don't want to kind of rapidly reach. I want to reach at the right speed that I pick up something. Or if I'm falling, I want to make sure my hand is in the right exact position to stop me from falling. So we modify our reflexes, and a lot of that is done subconsciously in an area of the brain called the cerebellum and in what are called the extrapyramidal pathways. I'm not going to go into the anatomy of the extrapyramidal pathways. That would take 2 years. But just to give you an idea that reflex control is not as simple as we might originally have thought. So yeah, there's spinal reflexes and there's how they're modified at a cerebral level. And part of how they're modified at a cerebral level is maybe if you're stung by a wasp, how you respond to that might depend on the circumstance that you're in. So if you're lying on the beach in Corfu or wherever, and you're chilled, completely chilled, and just lying, taking in the sun, and you get stung, you can appreciate in that situation the stingy might be, sort of jump and get all agitated, etc. On the other hand, if the person who's stung is a soldier in a dangerous area in Afghanistan or Gaza or wherever, they're not going to even flinch. So that's the extent to which we can consciously override our reflexes if needs be. And that kind of highlights the importance of having cerebral control or intracranial control of what happens at a spinal level. So spasticity is then where we have reflexes that are designed to control our balance and posture, but where we've lost that overriding control, right? So whether it's due to brain injury or spinal injury or stroke or whatever neurological condition, but if you lose that upper motor neuron control, you lose your ability to override your reflexes. So your reflexes are just firing continuously with no modification. And that's how muscle spasm happens, or how spasticity happens. And probably the surprise in all that is maybe that spasticity isn't a greater problem than we do encounter. But that is why spasticity happens. So you'll hear oftentimes people talking about lower motor neuron injury and upper motor neuron injury. So a lower motor neuron injury is one that happens outside of the spinal cord. It happens in the peripheral nerves or maybe just adjacent to the spinal cord. Whereas an upper motor neuron injury is anything that involves the spinal cord or the brain. And with an upper motor neuron injury, you lose that regulation of your spinal reflexes. With a lower motor neuron injury, you just lose the reflex. So if you've got a motor injury that's out with the spinal cord, your muscles can't move. But they're not spastic, they're not rigid, they're not overreactive. If it's an upper motor neuron injury, there's no regulation of the reflexes, so your muscles are overactive, but in an uncontrolled way, or to use the term we use, you've got spasticity. So the next kind of theme is maybe not very anatomical, but it's maybe to try and help people understand why the difference between clots that we worry about in terms of clots in the lung, clots in the leg, versus clots that cause strokes. And the first thing in that is to maybe try and understand, well, how do clots happen? So clots, in theory, are good things, right? If you cut your skin and you start to bleed, unless you have a clotting mechanism, you could potentially bleed to death. So the body has to have a system of stopping bleeding. And it does that using cells in the bloodstream that are called platelets and using what's called a coagulation cascade. And a coagulation cascade is basically loads of different chemicals that trigger each other into a response that ultimately leads to forming fibrin strands, or kind of strands that will trap the platelets. And the combination of all these chemicals forming these strands and the platelets plugs whatever hole is created when you bleed. So in microscopic level, you get that kind of appearance when you get a clot. So that's all very good, but sometimes people get clots in their leg. And it's usually a thing that's associated with the combination of immobility and inflammation. So if you've had an operation and you're immobile for a few days afterwards, that's probably the time you're most at risk of getting a clot. Or if you have pneumonia, or if you have some serious infection and you're immobile for a period of days, that's when you're most likely to get a clot, okay? And the clot is more likely to happen in your legs because drainage from your veins in your legs is dependent on mobility of your legs, okay? So we very rarely, at the end of the day, notice swelling in our hands or in our arms, but quite a lot of us will notice at the end of the day our legs are swollen, right? And the reason why is that drainage in the veins doesn't work quite so well, and it relies on muscle pumps to pump blood back to the heart. So if you're going to get a clot that's due to immobility, it's much more likely to happen in your calf muscle. And that clot can then travel in your venous system, but it can only get as far as your lung, okay? It doesn't... Within the heart, there's a kind of a right-sided set of passageways and a left-sided set of passageways, and unoxygenated blood coming back from the rest of the body can only go in one direction, and that's to the lung. So a clot in the leg can travel to the lung, but it can't really travel anywhere else. On the other hand, clots that cause strokes can only originate in that part of the circulation that directly feeds the brain. So how do clots happen when they're not supposed to happen? So part of it is initially about, you've probably heard of the concept of people getting plaques building up in their blood vessels, right? So the higher your cholesterol level, and the higher your blood pressure, the more likely it is that you're going to get cholesterol deposits infiltrating the wall of your arteries. Okay? So over a period of time, those cholesterol deposits can build up. So you start off with, oh, this doesn't work very well. Okay, hopefully you can see that. So you start off with what looks like a normal healthy artery, then a small little plaque building up, then a bigger plaque building up. And ultimately, you could possibly get a plaque that builds up so much that it blocks an artery completely. And when you hear of people having surgery to their carotid arteries to unblock the carotid arteries, it's that kind of blockage that's being released. The other thing that can happen, though, is you might have a plaque that's not completely blocking an artery, but plaques are not very stable structures. And sometimes the surface of a plaque can be easily disrupted or broken. And if it's broken, that triggers a clotting mechanism. So then you can get a clot forming at the site of the plaque. And a clot will build, whereas a plaque takes months or years to build up, a clot can build up within seconds or hours. And if that clot blocks the artery where that plaque is, you get no blood supply beyond that, and that's how strokes happen. Okay. Sometimes what happens is the clot forms, and it dislodges, and it travels in the bloodstream, and it might keep traveling until it gets to a smaller blood vessel, and then blocks that blood vessel instead. So sometimes you hear the term thrombus, and sometimes you hear the term embolus. So a thrombus is a clot that blocks an artery where it originally formed, and an embolus is a clot that broke off, traveled until it got to a smaller blood vessel, and then blocked the artery. So that's roughly how about 85%, 90% of strokes happen in terms of arteries being blocked by clots. And you'll sometimes hear us talking about ischemia or infarction, or you've heard of the term transient ischemic attack. So ischemia is a term that describes a temporary lack of oxygen, and it's generally reversible, whereas infarction is where you get tissue death that happens due to a more prolonged loss of oxygen. So a stroke is typically an infarction, whereas a TIA, when you hear people talking about TIAs, is an ischemic event that is reversible. Well, that suggests that there's a risk of the same thing happening again. So we sometimes talk about hemorrhagic strokes, and I'll come on to that in a little while. But most strokes, when you hear of them, are either that they're basically infarction that is due to thrombus or embolus. Don't know if anyone wants to ask a question before I move on. So, yeah, the start of this is a bit stroke focused, but it will become more and more traumatic brain injury focused as well. So the next thing to explain is maybe how circulation works in the brain. And this is relevant not just to stroke, but also to people who've had hemorrhagic brain injury, in particular subarachnoid hemorrhage. So the brain is supplied by 4 principal arteries. Most of you have felt your carotid pulses here, right? So there's a carotid artery on either side. That is probably the main supplier to the brain. And there's 2 more arteries that travel up next to your vertebrae that are called vertebral arteries. And when the 2 vertebral arteries get into the brain, they join up to become what's called the basilar artery. Okay, so they form one single basilar artery. And the basilar artery and the 2 carotid arteries all join up together to form what is called the circle of Willis. So the circle of Willis is kind of a network of blood vessels that links the main artery supplies to the brain. Now, why we have that circular network, it's hard to be clear why, but it may well be an evolutionary thing. The benefit of having this circle of vessels is that if one of them gets blocked, that in theory you might possibly get reverse flow from the other 3 to compensate for the blockage in one. So you can get what's called collateral circulation. So there is a kind of a benefit to having a circle of Willis, but unfortunately the circle of Willis is where a lot of problems tend to happen as well. So that's the circle of Willis. This represents the carotid artery coming up from the neck, and the main branch of the carotid artery is the middle cerebral artery, which supplies this area of brain here. But there's a branch that goes off as the anterior cerebral artery, which supplies the front of the brain. And in terms of the vertebral arteries, there are branches off here that supply areas like the cerebellum and the posterior aspect of the brain. So when people have strokes, you'll sometimes hear the term used that they've had an anterior circulation stroke or a posterior circulation stroke. And that basically describes whether the stroke involved one of the arteries that's a branch of the vertebral arteries or one that's a branch of the carotid arteries. The other importance of the circle of Willis is when people get subarachnoid hemorrhages, and I'm going to explain in a little while what aneurysms are, but when you get aneurysms, they typically tend to be in the area of the circle of Willis. In sorted diagrammatic form, the middle cerebral artery, the main branch of the carotid artery, supplies that area of the brain. This is kind of looking at the inner aspect of the brain. If you split down in half and had a look at the brain from the midline, you'll see that the anterior cerebral artery supplies most of that midline area, and this is the area in blue that's supplied by posterior circulation. Many of you will have seen diagrams of the brain representing the different functional areas. So what we call executive function is mainly a frontal lobe area. So that's kind of a lot, well, I'll come to executive function in a while. This area here in the lateral surface of the brain is where we're aware of sensation and where we have motor control. This area at the very back relates to vision. This area here is mainly about speech interpretation and speech production. And in terms of cognitive functions, there are so many different areas of the brain involved, it's kind of difficult to kind of highlight one in particular. And then in this strip of brain here, highlighted in red here, is what's called the motor cortex. And different parts of the body are represented on different parts of that cortex. So if you get a stroke that affects, if you get a loss of circulation to this part of the brain here, or what's up at the very top here, it will affect trunk and hip and thigh movement, but it probably won't affect foot movement or hand movement. So that kind of explains why sometimes when people have a stroke, it doesn't affect their whole left side, it might just affect some individual muscle groups. Right, anoxic brain injury is next, and some people use the term hypoxic brain injury, some people use the term anoxic brain injury. In the States, sometimes they even use the term hypoxemic brain injury. But they all basically mean the same thing, which is that the injury is due to a lack of oxygen getting to the brain. Except it's not always due to a lack of oxygen getting to the brain. Sometimes it can be due to a lack of glucose getting to the brain. Okay, so oxygen or glucose-like chemicals that provide energy are key to the brain functioning. And if you stop that supply for a period of minutes, the area of the brain that's affected potentially dies. So there are various different ways in which that can happen. So going from the first column across, so sometimes it can be just because you're not getting oxygen into your lungs, either from hanging or drowning, carbon monoxide poisoning, or someone who's got a severe respiratory condition that causes respiratory failure. Second column is about people who have sudden blood loss. So if you have an injury that involves, say, a laceration to one of your larger arteries, like say your femoral artery or your brachial artery, and you lose a lot of blood really quickly, that might affect your ability to deliver oxygen to the brain. Cardiac arrest is probably the most common cause that we come across. So if your heart stops beating for 5-10 minutes, you're not getting oxygen anywhere, but your brain is the tissue that's most vulnerable to that. Then the next one is a little bit more complicated, but when people have overdoses, it depends on the type of medication they might take. But some overdoses cause cardiac arrest. Some overdoses can cause seizures, which have an impact on circulatory delivery to the brain. And some can cause your blood sugar to drop quite dramatically. So some combination of that kind of process means that your brain's either not getting enough nutrition or not able to use the nutrition it's getting. And finally, if someone has a really prolonged seizure, a seizure, first of all, increases the oxygen demand that the brain has, but a seizure also can impact on your on cardiac function and your heart's ability to deliver oxygen to the brain. So a whole variety of causes, and that's one of the reasons why anoxic brain injury isn't maybe so well recognized as traumatic brain injury, because anoxic brain injury can happen in a variety of different wards, and I've sort of listed the different venues that it can happen in. And in each of those wards, the patient who has the anoxic brain injury is seen as a survivor. You've had your cardiac arrest and you're alive, hey, it's brilliant, all right? And oftentimes families sort of see the same, and if the patient seems a bit confused, well, you know, he's had a cardiac arrest, we kind of expect him to be not right for a few weeks, you know. So oftentimes it takes a few weeks for people to realize actually there's something more substantial that's developed here. So areas of the brain that are most affected in anoxic brain injury is very much influenced by circulation. So the bottom left picture here shows an angiogram of, that's the middle cerebral artery going up the outside, and that's the anterior cerebral artery. And you can see that in this area in between the two, they're fairly remote from the arterial trees. And if your blood pressure suddenly drops, or if your oxygen level suddenly drops, or if your glucose level suddenly drops, then that's the area of the brain that's most vulnerable to damage. So in the brain, there are various what we call watershed areas, areas where that are more vulnerable if you're without oxygen or glucose. And in a very sort of crude way, they're highlighted at the top of the page here. And I've listed them here, but basically the areas most prominently affected are what's called the visual association cortex, which is not the area of the brain that identifies what you see, but it's the area of the brain that maybe describes what you see. Okay, so people with anoxic brain injury can actually see, but can't tell you what it is. So a simple example would be if you threw something to them, like a ball, they'd be able to catch it because they've got the visual reflexes to see something's coming and catch it, but ask them to describe what they've caught, they won't tell you. Sometimes if we have cleaners in the ward, and you know the way they have these kind of yellow triangles to say wet floor, and if you walk someone with an anoxic brain injury along the ward, they might actually step out of the way of the yellow triangle, but ask them why they did it, they won't tell you. So it's about visual interpretation rather than actual seeing as such. Other areas of the brain that are affected are the hippocampus and the parieto-temporal area. So parieto-temporal is here, but hippocampus is quite deep. And they're involved in memory, and people with anoxic brain injury tend to have very profound recall impairments. They might have other cognitive functions might be relatively well preserved, but recall is quite poorly preserved. And then the other area that's affected is the basal ganglia, which is a kind of a structure that's deep within the brain. And if you remember me mentioning about extrapyramidal pathways and control of movement, so the basal ganglia is involved in control of movement. So people with anoxic brain injury quite commonly might have good strength, but very poor control of how they use that strength. Yeah, that's just another diagram explaining the visual issues. So people with the visual spatial awareness, one simple test that we can do sometimes is ask them, on the picture on the right, there are 10 different objects, and to ask them, you know, can they name what the 10 objects are? And that might be relatively easy for you or me, but if you've got visual spatial impairments, you're going to struggle to pick out those shapes from each other. Or on the chart on the left, you might ask them to put a circle around the larger stars. And sometimes what you might find is that on one side of the page they perform quite well, on the other side of the page they might not perform quite so well. So that's called a star cancellation test. So there are various different ways of testing that visual impairment. Traumatic brain injury. So there's a lot happens in traumatic brain injury. In the first hour or so, or the very immediate impact, there's the effect of diffuse axonal injury, which I'm going to explain in a minute. You also get bruising and bleeding, which can cause local damage, or it can cause pressure in terms of adjacent areas. Fractures can sometimes cause direct damage to underlying brain tissue as well. Then there's delayed effects, and oftentimes the delayed effects are actually the more of the problem. So if you get an injury, if you got an injury to your arm, it wouldn't surprise you if your arm swelled up over the next few hours. If your brain swells up, it doesn't really have any space into which to expand. There's a bony box that keeps your brain in place. So if you get swelling, you get pressure developing in a lot of different tissues within the brain. And anytime you get swelling, there's always a risk of infection. So that can develop in later days, particularly if you've got fractures as well that allow infection in. And with swelling comes ischemia, because if you're compressed by brain swelling in one part of the brain, and the adjacent tissues are going to be compressed and have reduced circulation for that reason. So there's a few different reasons for why people with traumatic brain injury get brain damage. In addition, people who get brain injury oftentimes get other injuries as well. If it's a fall downstairs, you might get an injury to the outstretched arm and you damage a thing called a brachial plexus. If you fall off a bike or if you're in a car accident, you might get a spinal injury as well. Or you can get other musculoskeletal injuries, other fractures, etc. So, diffuse axonal injury. When you get a blow to the brain can sort of reverberate or rebound within the skull, sort of shunting over and back. But sometimes it does it in a kind of a rotational way as well. It might not just be a forward and back movement. And as it does that forward and back movement, there's compression of different structures within the brain. So while you might get bruising at the front here, you can also get bruising at the back. So the term we use is a coup and a contra-coup injury for people who have injuries at both sides of the brain following an impact. But what can also happen is the brain is a multi-layered structure, and there are sort of weak points between some of these layers, and these layers might get disrupted relative to each other. And when they get disrupted, you can get a variety of things happening, such as you can get twisting of individual nerve fibers, or stretching of individual nerve fibers, or compression of individual nerve fibers. And that all happens to individual fibers, but maybe not every nerve fiber in a particular area of the brain. So it's the kind of thing that might show up on a microscope, if we could put microscopes into the brain, but we can't, obviously. But it's not the kind of thing that would show up on a scan necessarily. So when people get this kind of diffuse pattern of axonal injury, an axon being another word for a nerve fiber, so if you get a diffuse pattern of axonal injury, it's something that doesn't show up on scan. You might be told the scan looks normal, but we still know that there's damage happening because of the pattern that happens following traumatic brain injury. And there are certain areas that are more vulnerable to diffuse axonal brain injury. The base of the skull, if you were to cut open the skull and look down inside, looks like this. And you'll see there's lots of bony ridges at the base of the skull. So each ridge creates a kind of a friction or a shearing force potential as the brain gets shunted forward and back at the time of injury. So this kind of this friction potential adds to the potential for diffuse axonal injury. And there are certain areas of the base of the skull that are particularly vulnerable. So at the very front, there's where the olfactory nerve is, the nerve of smell. It passes through what looks like a kind of a pepper pot arrangement at the base of the skull. So the nerve breaks up into a whole load of fibers, and when you get this forward and back effect, those fibers are particularly vulnerable to damage, which is why people with traumatic brain injury oftentimes complain of loss of a sense of smell, which has an impact on their sense of taste as well. The pituitary gland sits in a kind of a bony box at the base of the skull. And the pituitary gland is the gland that controls hormone production throughout the body. And there is some evidence to suggest that the pituitary gland can be damaged in traumatic brain injury. And there are a lot of research trials that are produced in ITU patients suggesting that pituitary damage is quite common. On the other hand, we've been screening for it for 10 years and we've found very, very few cases. So I think there's maybe something about the way in which patients for these trials are recruited, but there certainly is a potential for pituitary damage at least. And the third area then that's affected is the base of the brain, or the brain stem, which links the spinal cord to the brain, lives in this sort of hole at the base of the skull called the foramen magnum. And you can imagine that if the brain is being shunted forward and back, that the brainstem becomes a kind of a hinge, which is much more susceptible to shearing forces or friction forces as a result. So that's a bit of a diagram as to what the olfactory nerve looks like, the nerve of smell. So it basically looks like a sort of a toothbrush squashed down into these little pepper pot openings, and you can kind of see where any friction force is going to create a lot of damage there. So again, there are certain areas in the brain that are more vulnerable with traumatic brain injury. The frontal area of the brain, because that's where we're most likely to get injuries. If we fall down the stairs, if we're in a car accident, if we're in a bike accident, whatever, you're much more likely to get hit here, or possibly in the parietal areas. But it's quite unusual, other than in an unprovoked assault, it's quite unusual to get an injury to the back of your skull. So frontal areas and parietal temporal areas, frontal areas are very much focused on executive function, and my next slide will sort of summarize what executive function is. Parietal temporal areas is motor function, and also some cognitive activity and speech production as well. And then areas at the base of the brain, because they're closer to those bony ridges in the skull, they're more vulnerable to friction or shearing effects. And then the structures that are particularly vulnerable there are, again, the basal ganglia, which I spoke about with an oxic injury, which involves motor control. So again, you may oftentimes have a traumatic brain injury patient who doesn't have that much loss of power, but who has very poor coordination or who has problems with spasticity. Executive function is kind of difficult to describe, but it's that kind of cognitive activity that controls other cognitive functions. It's the kind of thing that makes us behave appropriately. It's the kind of thing that allows us to do flexible thinking or abstract reasoning or planning or strategizing. And most of those functions are in the frontal lobe of the brain, which is why when people have a traumatic brain injury, that oftentimes behavioral problems or having insight or appropriateness can be the functions that are most impaired. So I think this is the final section, okay? So, which is just as well because I've run out of time. Right. So there is, within the brain, there is a sort of a second circulatory system. In addition to our bloodstream, there's a thing called CSF, or cerebrospinal fluid. And cerebrospinal fluid is produced partly in a thing called the choroid plexus, which is within the ventricles, but it's also produced within an area called the meninges. So if you work your way in from the top here, where's my little red light? Oh, there we go, yeah. So that top layer is skin, next layer is sort of other soft tissue, bone, as in the skull, and then you have these layers called the meninges. And well, you've heard of meningitis, and meningitis is inflammation of the meninges. So there are three layers of meninges. There's the dura mater, the arachnoid mater, and the pia mater. And between these layers, there are certain there are things called arachnoid granulations, which link from the bloodstream and leak fluid into this space here to produce CSF. Some of the larger blood vessels in the brain lie within these layers as well. And I think, yeah, CSF is also produced in the center of the brain in a thing called the choroid plexus. And if you've heard of ventricles, there are these fluid chambers that lie within the center of the brain that ultimately have a link to the CSF spaces that surround the brain as well. And CSF is partly about local nutrition, it's partly about just buoyancy for the brain, okay? But if your CSF drainage system gets blocked, that's when people get issues with hydrocephalus. So, yeah, one more slide to come. So the layers of meninges, they don't just sort of wrap the brain, they also provide some support within the brain. So there is a kind of a bit like during the pandemic, we had these sheets of plexiglass. You know, if you went into your post office or into a restaurant, there was these sheets of glass that separated you from someone else. So you kind of have that sort of effect created by the meninges, where there's a vertical sheet called the falx cerebri, which separates the left side of the brain from the right side of the brain, and there's a horizontal shelf, which is called the tentorium, which supports the cerebrum and separates it from the cerebellum. Which is all very well, but sometimes if the brain swells, these sheets can actually prevent expansion and can cause problems with a thing called herniation. Another slide coming up. So, yeah, that's the role of the meninges. The ventricles are these fluid collections that lie deep within the brain, and the two slides on the left, or the two images on the left, are what they look like normally in size. But if someone gets obstruction to their CSF drainage, if they get a thing called hydrocephalus, you can get that amount of swelling. And if that amount of fluid builds up, that creates pressure effects throughout the brain. So when you hear of someone having a shunt put in, it's to release that kind of pressure. When pressure builds up, whether it's due to hydrocephalus or whether it's due to blood, the falx cerebri that I spoke about prevents, if you have a big collection of blood here creating pressure in the brain, the falx cerebri prevents or reduces the potential for midline shift. But what it also does is it means that some areas of the brain can squeeze under that falx. So if you hear the term herniation of the brain, it can be a kind of a horizontal herniation there, or it can be a vertical herniation down here. And herniation in itself causes problems with ischemia or blockage of blood flow. So terms like herniation, hydrocephalus are generally not terms you want to hear, but hopefully that gives you some ideas to what's meant by those terms. And finally, what happens in hemorrhagic brain injury? So you can appreciate with a tire, if there's a weakness in the wall of the tire, that as you keep pumping that tire up, it'll start to bulge. And if you keep pumping it up, it won't surprise you that that'll burst. So that's a little bit like what happens when someone has an aneurysm. So normal circulation looks a bit like this. The red vessels at the bottom are arteries delivering oxygen to brain tissue or other tissues in the body, and the blue vessels at the top are veins that are taking away that circulation, the unoxygenated blood. And sometimes you'll hear the term AVM if someone has an arteriovenous malformation, and that's where the connections between the arteries and the veins, instead of having small little capillaries, you actually have larger vessels. For reasons that it's just not possible to explain why. But these larger vessels, because they're abnormal developments, and they've probably been there since birth, they have a potential to rupture more easily than ordinary capillaries have. Because they're made of a tissue that's not designed to sustain the continuous high pressure that you have in arteries, so over a period of time they gradually expand and potentially rupture. An aneurysm is a slightly different thing. An aneurysm is usually within an artery where there's a small bulge, a bit like what I showed you with the tire, but if your blood pressure increases, that bulge can increase in size. And if your blood pressure keeps increasing, well, that bulge can increase more and more and ultimately rupture. And treatments for aneurysms, you've heard of clipping and coiling, presumably. So clipping is done surgically, where a surgeon can open up your skull, find the artery, and put basically a metal clip around the root of the aneurysm just to close it off. Coiling is done by using angiographic techniques, so it involves putting either through your wrist or through your femoral artery, putting a very, very thin metal wire, pushing it all the way along up the blood vessel, watching under X-ray control until you can, they've techniques for guiding it to go left and right at different junctions, etc. But until you know that it's actually inside the aneurysm. And once it's in the aneurysm, you keep feeding through a bit more wire so that it kind of becomes like a bit like a wire, the scrubbing things that you make of wire. Yeah. So you get a bundle of wires, and then you pass a current through it, which makes the blood around those wires clot and block off the aneurysm. So that's basically what coiling looks like. And this is an angiogram. So this is what normal blood vessels look like. These are the two vertebral arteries feeding into the basilar artery. This is where the circle of Willis should be, but instead what's there is an aneurysm. And after treatment, there's no blood, the aneurysm's gone. So different type of hemorrhages. You'll hear of people having extradural hemorrhages, subarachnoid hemorrhages, etc. This all relates to the meninges as well. So working from the top, between the skull and the dura mater is where you have the largest blood vessels in the brain. And if you have a high velocity injury, they're the vessels that are much most likely to rupture. Because they're large, the bleeding just pours out at a really fast rate. So an extradural hemorrhage is usually something that's an emergency and has to be operated on there and then. Subdural hemorrhages involve smaller vessels that are penetrating from the extradural space to the subarachnoid space. They're usually, when they rupture, it's not because of the velocity of the injury. It's oftentimes a very low velocity injury. It's oftentimes an injury that the patient doesn't even know they've had. But it typically happens in older patients, and it happens because the vessels themselves are a little bit more vulnerable to rupture. Okay? So subdural hemorrhages are usually low velocity injuries. They're small blood vessels. The blood collects over a very long period of time. It's not a surgical emergency, but sometimes does require surgical drainage. Subarachnoid hemorrhages are almost always due to aneurysms or AVMs. They're in arteries that have quite high pressure within them, but the subarachnoid space is a much tighter space than the extradural space. So if you get bleeding into the subarachnoid space, it's not just going to expand and cause pressure on the brain, the blood is actually going to filter laterally around the subarachnoid space and cause local pressure effects instead. So it's not the kind of thing that you can open up the brain and just drain the blood out. Usually with subarachnoid hemorrhage, you treat the cause by doing coiling or clipping. And then finally, within the brain tissue, away from the meninges, you can have smaller blood vessels again that if they rupture, usually due to high blood pressure, or can be because of blood thinning medications, but if they rupture, the bleeding is direct into brain tissue. It can't spread very far because brain tissue doesn't allow the bleeding to expand very far, but you get a localized bleed, and when people have a hemorrhagic stroke, usually it's because of an intracerebral hemorrhage. I think that's us. I had a few slides on disorders of consciousness, but I think I've run out of time, yeah.